So while people are getting sat down, just like just Grace Kansame, she's a nephrologist and researcher at Mabara University of Science and Technology. She did her undergraduate training at McMaster's International's Medicine from Makerere University, and then went on to do a fellowship at McMaster University in Canada. She's head of the department at the Makerere University of Science and Technology Teaching Hospital. And she's very passionate about improving the health and welfare of patients, and also in education. And her talk today is going to be about acute kidney injury among patients with tuberculosis. And that's actually really important because certainly we are seeing an increase in tuberculosis in the UK, and we might be able to learn something from her experiences. So I'm going to pass over to Grace. Grace, over to you.
Thank you. Thank you very much, Stin. So it is starting to rain here. It's a rainy season. I'll put off my video and hope my internet will hold. So thank you very much, the organizers, for this educational event. Thank you for inviting me. Thank you for joining in, our dear listeners. So I'll be talking to you about our findings from the study, looking at the incidence of acute kidney injury and its associated mortality among individuals with drug-susceptible tuberculosis in Uganda. And this here is the team. This project was undertaken as part of a research fellowship, which was supported by an NIH grant called the Multimorbidity Research Capacity Initiative. So we know that acute kidney injury is defined as a sudden decrease in kidney function, which manifests either as an increase in serum creatinine of more than 0.3 milligrams per deciliter within 48 hours, or more than 1.5 times the baseline, or whether it's known or presumed within the 7 days, or a reduction in urine output within 6 hours. And those are the usual standard AKI stages. So, however, for this study, we defined acute kidney injury as sudden decrease in kidney function, manifesting as a 50% relative increase from the serum creatinine, which was imputed from an imputed baseline. Because as you know, in our setting, most people usually do not know their creatinine, and we may not know what it has been before they present you in hospital sick. So we had an imputed baseline, but also for those that in whom we took day 0 or baseline to be baseline creatinine, we then diagnosed their acute kidney injury at day 7, still as a 50% increase from that baseline. So we know that tuberculosis is associated with significant mortality and morbidity. However, its impact on kidney function is not very well understood, and oftentimes it is attributed to the TB drugs, not the TB itself. So previous studies have shown that an incidence of 7 to 10% of AKI among patients with tuberculosis. So we aimed to assess the incidence of acute kidney injury in the immediate post-TB diagnosis period in Uganda. So as we know, Uganda is among the 30 high-burden TB and TB HIV endemic countries. So to put it in perspective, the incidence of TB in Uganda, this is usually a yearly incidence. So in 2022, the World Health Organization reported that Uganda had an incidence of 199 cases per 100,000 people. While the National TB Survey reported an incidence of 253 cases per 100,000 in the same year. So you can tell that the incidence of TB in Uganda is 200 to 250. And to put it into context, so compared to the UK and the US, In the US, for example, the incidence among the US-born citizens is 0.8 cases per 100,000, while in the non-US-born citizens, it is 15 cases per 100,000. And in the UK, like Nid says, their incidence has been increasing, but it increased from 7.755% per 100 cases, per 100 population in 2022 to 10.7 in 2023. So yes, it is on the rise in the UK, as he says, but you can see, we would think that it's negligible compared to where we are. And the World Health Organization takes a cutoff, if I can use that, of 10 cases per 100,000 to decide that a country has a low incidence or a high incidence. So you can see why. And the reason we did this study, studies that have been done in Uganda looking at kidney disease have found that most patients with kidney disease do not have the traditional risk factors of hypertension and diabetes. And we think that infections contribute a great percentage to kidney disease. So looking at malaria and then TB in this case. So what did we do? So this is a prospective observational cohort study. It is still ongoing of adults with drug-susceptible TB, and we intend to follow them up for 2 years. So adults above 18 years without a known history of kidney disease were enrolled between August 2022 and July 2023, within 7 days of TB diagnosis at 3 regional referral hospitals in Western Uganda. So this is Mbarara, Kabale, and Masaka. And these 3 regional referral hospitals serve about 12.5% of the Ugandan population. So our primary outcome was the incidence of KDIGO-defined AKI within 2 weeks of TB diagnosis. So if I have been enrolled when I have already had my diagnosis for 7 days, then we follow you up for another 7 days. So that's why the 2 weeks. But we also looked at the outcomes, including predictors of AKI and mortality or survival, 30-day survival after AKI diagnosis. So this is the study flow diagram. We screened a total of 345 adults during this period at the 3 sites, and several people were excluded for various reasons, and we ended up with 161 participants. So of these, 83 were HIV negative, while 78 were HIV positive. Within that 1 week, before we could repeat the serum creatinine, we lost 1 patient among the HIV positives and 4 among the HIV negatives. So on day 7, we had 149 because some had died. So by 30 days, we had 138 still because some had died. So in terms of results, these were our participants. The median age was 39. So as you can see, they are young people. The HIV group, they were slightly older. They were mostly males. As you can see, females are only 49%. So in terms of symptom duration from onset of symptoms to presentation into hospital, on average, those that were HIV positive had symptoms for only 21 days compared to 60 days among the HIV negatives. And kidney function at baseline was really when you look at people with HIV, the eGFR was 104, but is slightly lower among those with HIV compared to the HIV negatives. So of this whole cohort, 49% were HIV positive. Of those that were HIV positive, 43% were on ART, but majority of them had a low CD4 of less than 200. So in terms of our results, looking at the incidence of AKI, we found that 33.3% of all the participants had AKI. And of these, so if you came in at day 0, on the very day we enrolled into the study, and we found that you had a high creatinine, of these 23, 27 were diagnosed on that day 1, and 25 were diagnosed later on day 7. So among those that did not have AKI at enrollment, we then did their creatinine at enrollment and creatinine at 7 days, and of those, 25 had AKI. But as you can see, most of the participants had stage 1 AKI and stage 2. Only 3 had stage 3. And these were not different. If you look at either HIV positives or HIV negatives, there were no significant differences in the incidence of AKI. So in terms of factors associated with AKI, among those that did not have AKI at enrollment, we looked at having any proteinuria or hematuria at enrollment and compared it with the possibility, the odds of getting AKI by day 7. And we found that those that had any degree of proteinuria or hematuria had higher odds of AKI by day 7. And looking at the 30-day outcomes or survival, those that had AKI, be it at baseline, be it at day 7, they had higher odds of mortality. And this was regardless of their HIV status. So as you can see, whether those that had no AKI, which is red, and those that had AKI, the odds of mortality were really higher among those that had AKI, as you can see the blue line. But when we look at those that had HIV versus those that did not, there is really no significant difference. So because, remember, we used an imputed creatinine, we usually don't have baselines for most of our patients. So we tried to look at the trajectories of creatinine from baseline to day 0. And as you can see in figure A, this is where we have an imputed creatinine. So if we imputed your creatinine, and that is what we called the baseline, showing that at day 0, so if you follow the blue or green lines, whatever you would like to call them. So looking at day 0, we can say that your creatinine had gone high, and so we diagnosed you with AKI. And as you can see, for most of them, by day 7, the creatinine had come down. All had gotten worse for some of them, meaning that it was an AKI by the time we got you, because we did this we wanted to make sure that it is not a CKD that we've misdiagnosed as AKI. So as you can see, most of our people that we had diagnosed with AKI from an imputed baseline creatinine, by day 7, their creatinine was going down, showing that indeed this was an AKI. And in figure B, it shows those that were diagnosed at day 7. So they came at day 0, they had a normal creatinine, and then their creatinine was going up by day 7. So we conclude that the incidence of TB-associated AKI in this immediate period after TB diagnosis is high and associated with significant risk for mortality, regardless of the HIV status. So as I've kept alluding to, most patients in our setting really do not know their kidney function. So we recommend that all patients diagnosed with TB should have their kidney function assessed and monitored routinely, irrespective of their HIV status. But what this study also showed us is that people who are under HIV care, so HIV care is not just benefiting them by getting the care for HIV, but as you can see, they had their diagnosis early. So the benefits go beyond the HIV care, because now you come in, you have any symptoms of weight loss, or you're not feeling fine, or your CD4 is going down, we look for TB. We do urine lamp. There are all these things that have been put in place to actively look for TB among patients with HIV, which is not the case for HIV negatives. They are treated in the lower health facilities as so many things until when it is too late. As you can see, they are being diagnosed on average 2 months later. So we recommend future work in this area to focus on longitudinal kidney function, underlying mechanisms of AKI, and early predictors of mortality. Hopefully that these, if they are attended to, they can improve outcomes among this patient population. So I acknowledge the funders for this study, my mentors headed by Dr. Kale Subla, by the whole study team and staff, and all study participants, and thank you very much for listening.
Many thanks, Grace, for a fascinating talk. Just one question. You demonstrated that the mortality with AKI associated with TB was significantly higher. How does that compare to the mortality from other causes of AKI that you see?
Wow, that's a good one and that I hadn't thought about. But when I think about it now, so first looking at TB alone, patients with TB come to us, they start treatment, and significantly knowing that these are patients who have drug susceptible tuberculosis, so they get treatment, they should get fine, but they die and we do not know why. So now we are thinking AKI is contributing to this mortality. When we look at other conditions, let's say malaria, let's say sepsis, it still increases mortality. But what we really wanted to bring out in this study is that whenever someone comes in with any other sepsis or malaria, everyone will look out for AKI because everyone knows that this is a complication of this disease. So they tend to conservatively manage the patients, look out for the AKI, give them fluids, which is not the case in TB patients, that no one would be thinking about this. So I wouldn't say this is higher or lower, but I think that's really my thinking, that people usually, you have TB until you have signs and symptoms of body swelling or complain that you're not peeing, we would not actively start looking out for AKI because it wasn't one of those things up there.
And just as a follow-up, Charlotte asks, so what do you think the main cause of AKI were? The TB itself, or the drugs, or other causes?
Thank you for that, and that's a very good question. So we actually thought this was multifactorial. And sorry, maybe I didn't put out the limitation. So for example, as we show that patients were coming late, we were not able to ascertain what they were taking in all this time while they were away. Was it herbs? Was it NSAIDs? But then because they've been sick for so long, some of them would come in with sepsis, a bit of hypovolemia. So it is all that multifactorial. And what we significantly specifically wanted to show by showing that even at diagnosis of TB, before they initiate medications, as you can see, half of these patients already had AKI. So this AKI, so these 27 that were diagnosed on day one, so that is 50% of the 33%. So this AKI is not really due to the drugs. It is AKI that has been gotten from the community. By the time the patients are arriving and we are diagnosing them with TB, they already have AKI. Then these 25 are the ones that developed the AKI on day 7. So it's that multifactorial, and it is not just the drugs.
Great, thank you. And somebody asks, which of the anti-TB drugs could be more nephrotoxic? That's from Rita.
Thank you, Rita. So previous studies have really blamed rifampicin, and most studies have even gone ahead and taken patients off that treatment and then reintroduced them. In our study, we did not have even those that had stage 3 AKI, where they were all managed conservatively. As well, Dr. Kalies alluded to this in his presentation. We know that dialysis is not very accessible in our setting. So the patients were treated conservatively and got better. We didn't have to stop their drugs. We have some follow-up studies on this because this is just 30 days. So it is a cohort that is ongoing for 2 years. We shall be hopefully producing more results and publishing more papers about that, about the treatment outcomes, to see if those that got AKI later or ongoing kidney dysfunction had worse outcomes.
Okay, and just as a follow-up, Charlotte was asking, how frequently did you check the kidney function after 7 days over the 2-year period? And after that, what percentage of the patients with AKI ended up with chronic kidney disease?
Yes, so that one is sort of preempting what I was just saying. So we checked at 30. So we checked day 0, 7 days to get this AKI. Then we did 90 days, so which is 3 months. And here we were trying to see if there is resolution of the AKI. Then we did 6 months, 1 year, and then 2 years. So we have some people that have completed a 2-year follow-up. The study is still ongoing until July next year. So we shall be able to tell who will have resolution of their AKI. We hope to be able to tell the incidence of CKD within these 2 years. So we hope we shall answer those questions once we have those out.
And will you be able to tease out whether any of the anti-TB drugs had an effect on kidney function in that follow-up period?
And unfortunately, no, because, so like I said, most of the anti-TB drugs that have been thought to cause kidney injury are rifampicin and ethambutol. But in our setting, we have this drug, the combined pill that everyone swallows. So we will unfortunately not be able to tell because we don't do blood levels, we watch if you're getting better and we don't think you need to adjust the medication, so we don't adjust them. So unfortunately, we may not be. And even when patients go back home, they are likely to take other things that we are not able to get. Herbs, when they fall sick, they won't come to you, they'll still go to another health facility. So there is still a lot of information that we really can't correct to say that we are sure this is drugs.
And Rita asks, a follow-up question is, are there any precautions taken in initiating anti-TB medications in those with stage 3 AKI? So
thank you very much. So the 3 people that I show that had stage 3 AKI, these all developed AKI later, and they came in, when they came in on day 7 and we realized they had AKI, we admitted them, rehydrated them, and managed them really conservatively, discussed as the team if we needed to halt the drugs or not. So the only thing that we consider at the moment, and that's why we did the study to look out for the kidneys. So the only precautions we do that are in the policies and the guidelines at the moment is the liver injury, the drug-induced liver injury. But yes, if someone came in and they already had an AKI, you would consider several things. So you're considering drug dosing, and what would you do? So you can, if we had single pill medications, you would choose to use the other drugs that do not cause a lot of renal toxicity. So that is using everything else except the rifampicin and the ethambutol. All now you would discuss as a team and decide if to pull some drugs that are used for MDR to pull them into this regimen to manage the patient. Number 2, if you are in an area where you must use this single combination pill, you can decide to give the drugs on alternative days, or actually every 2 days. That's what we usually do in the dialysis population. So you can do that as you monitor the kidney function.
Great. Many thanks, Grace, for answering all those questions. And thank you for an excellent talk on TB and AKI in Uganda. So I'm going to hand back to my co-chair, Dr. Peace, to really present the final talk this morning.
Thank you so much, Grace, for a beautiful presentation. Thank you so much for the work that you're doing.